I want to be on point with that. Yeah, I would get ready to give it. She's what? Alright. Yeah, we'll see. Everybody ready? Anybody disagree with this? Okay. Where are we at? Conscientious innovation.
Hello everybody, my name's Nate. I am a working paramedic, and today we're going to be breaking down a cardiac arrest and the follow-on care. The original video was posted with the patient's permission. The original posters also did a video that is a little bit more geared towards healthcare professionals. While they did an incredible job, my goal is to make a video that is a little bit more accessible and is more of a breakdown for those of us who don't have as much of a medical background. Everybody made a full recovery. However, I recognize that still the content of the resuscitation may be hard to watch. With that said, everything presented here will be in an educational format, and we've made efforts to try to preserve the modesty of the patient. So without further ado, let's get into it. We see this crew gather their equipment and head into the house. This patient's friend called. They were exercising in the front room. The patient collapses and becomes unresponsive. The patient's friend saw this, checked a pulse, started CPR, and called 911. This patient's friend is very likely the reason that she had such a good outcome because, unfortunately, our response times are not instant, and the longer that someone goes without their heart beating, the more damage can happen to their brain. So this patient's friend very likely saved the patient's life. As we enter here, we see it's a very chaotic scene. Firefighters are already on scene. They are providing CPR. Our crew arrives, and we'll see what they do next.
Okay, you got that?
Yeah, we walk in, she looked like she's taking an annual respiration.
She have a pulse?
Does have annual?
I'm not breathing right now, yeah, keep going. I don't have a pulse.
So the crew here is saying that the patient does not have a pulse, meaning her heart has apparently stopped beating, but she is still breathing agonally. The patient may be taking very shallow or very deep breaths, but they are not at a high enough rate to adequately ventilate the patient.
Let's get some pads on. Got a timer going. Keep going, CPR.
I'm ready. Ready on 3. Ready? 1, 2, 3. Go ahead, man.
Check connector and electrode.
How are you?
Okay, we just ready? 3. Ready? 1, 2, 3.
Check connector and electrode.
Okay. You got pre-charge and all that?
Check connector and electrode.
We bagging and all that? You get an IJO?
So a couple things happened here all at once. The paramedic that is leading the call called to place pads on the patient. These are our defibrillator pads. While you may be familiar with in the movies the paddles that you charge up and shock the patient with, we no longer use those. We have these adhesive pads that stick to the patient. That way we don't have to figure out positioning for the pads every single time. We're able to deliver the electricity through those pads. Essentially what is happening here, if the patient is in what's called a shockable rhythm, meaning they're either in ventricular fibrillation or ventricular tachycardia, the electrical system in the heart needs to be reset. The way that we accomplish that is that we send electricity through the heart. Chest compressions and early defibrillation are the two things that are going to massively improve the chances that this patient survives the discharge, which she ultimately did. The other thing that happens here is the firefighters are getting ready to ventilate the patient. They place what's called an oral pharyngeal airway, or an OPA, which is just a very basic tool that keeps the tongue off the back of the throat to help open that airway. And they use what's called a bag valve mask to deliver breaths to the patient. Now, for those of you that may be more CPR trained or are more aware, The pad placement that they went with here is somewhat non-traditional, but there's a very good reason for that. This is called the anterior-posterior pad placement versus the anterior-lateral placement. It's been shown to be significantly more effective at terminating dysrhythmias, meaning it works much better than the traditional pad placement that we usually use, the anterior-lateral pad placement. If you're by yourself, not something I'd worry about, but when you have a full crew, as in this situation, we can go for these more ideal treatments than maybe would be possible if we're just completely alone on the side of the road, for example.
Okay, cool.
All right, 30 seconds for
A minute 30
CPR.
in. Oh, so you got
Yep, I have it.
She still has some respiratory drive. I'm more just assisting her at this point.
Yeah. All right, gonna pre-charge.
We hear that the paramedic is going to pre-charge the monitor. What this means is while we're still doing compressions, she's going to tell the device what level of energy she wants it to deliver so that it can charge and prepare to deliver that electricity so that as soon as we stop compressions, we're able to identify the rhythm that the patient is in, deliver the electricity, and then go back to CPR. The goal of this is just to minimize interruptions in chest compressions.
I got it. I'll do it again. I'll do it.
no history, no, this is.
Oh, no, keep going. Keep going.
No, just go, yeah. All right, we're gonna check in 5 seconds, y'all. 3, 2, 1. All right, pulse check.
Got it.
Yeah, okay.
Go for it.
Decent, clear?
Yep, shock it.
All right, shot.
Get back on, babe, back on. You got that ready to go?
All right, so this performed an excellent rhythm check. They paused, they checked for a pulse with and without compressions. As soon as the compressions were stopped, the patient no longer had a pulse. They identified the patient was in ventricular fibrillation on the monitor, which is a shockable rhythm. They deliver the electricity, and then they immediately get back on a CPR. The reasoning for this, instead of seeing if the defibrillation worked, is that sometimes defibrillation is not successful the first time. So instead of risking that extra pause to see if the defibrillation worked, we're just getting straight back into chest compressions to continue pumping that heart, because if the patient's heart is beating, chest compressions are not necessarily going to hurt them, and it is worth the risk in this situation. So from there, after delivering the electricity, we go straight back to CPR. We're still ventilating the patient with that bag valve mask, meaning we're delivering breaths, and the lead paramedic's partner is working on getting intraosseous access. That is where we put a needle into the bone to deliver medications. It's much faster than IV access and is a lot more reliable in a case like this where the patient does not have a good blood pressure or any blood pressure at all. This access will allow us to give some medications to the patient later on, which may help in the total resuscitation of the patient. That drilling sound was that IO being placed.
You wanna give me that ammo ready?
So they just mentioned get that amio ready. What that means is they're going to prepare a medication called amiodarone. If we shock a patient and they do not immediately convert, the procedure then is to continue compressions for another 2 minutes and prepare amiodarone. For the purposes of this, amiodarone essentially makes defibrillation more effective. It helps reduce the chaos that's going on in the electrical system in the heart. So they're going to have that drawn up and ready to go, and if they need to deliver a second shock, that will be the trigger to then give the amiodarone in addition to that second shock.
I gel's in. I gel's in.
Thank you.
You hear them say iGel is in. So the iGel is what's called a blind rescue device. It is another airway management device that is very simple. You essentially just push it down into the patient's mouth and it will seal around the trachea and plug the esophagus. This allows us to ventilate a little bit more precisely with that BVM and make sure that at least the majority of the air is going into the patient's lungs instead of into the patient's stomach.
Yeah, it's right there, man.
Right there, you just saw the paramedic place what's called capnography. This is inline capnography, where it detects the CO2 that is being exhaled from the patient. As you probably know, when you inhale about 21% oxygen, and that mixes with the air that's already in your lungs. As you exhale, there is much more carbon dioxide present in your breath than is present in room air, and we're able to detect that with our capnography device, and that just guarantees that we're ventilating the right place, aka we're putting air into the lungs and not into the stomach, and that readout will show up on our monitor.
Capno's looking good. Is that a 41 capno?
So they just said that the patient's capnography is 41. Capnography is a tool that we use to prove airway placement, but it also gives us an idea of what's going on metabolically with that patient. Higher capnography means the patient has been down as in cardiac arrest for a shorter period of time. On the whole, the better the patient's capnography, the higher likelihood the patient is going to have a survival and recovery from his cardiac arrest.
He's walking out with me.
30 more seconds of compression till next pulse check. Alright, we're gonna pre-charge. Keep
Yeah, you're
going.
good,
Ventilate.
5, 4,
Don't worry about that.
3, 2, 1. Pulse check.
Nope. The B-fib again.
Yeah, I got it.
Hit it.
Clear?
Clear. Good.
Nope. Back on
All right,
CPR.
back on check.
Amio's going in. 300 amio.
300.
Yes.
You got it? Oh, we'll wait. We'll keep doing CPR.
Yeah, keep going.
Looks good,
That
though.
looks better than what I
And
Yeah.
All right, so like I said, they made it about 2 more minutes of compressions. The patient was still in ventricular fibrillation, so they shocked the patient again. And now they're giving the medication amiodarone to hopefully make our further defibrillations more effective and maybe just terminate the dysrhythmia altogether.
How long was she down?
Immediate change.
amio flushed in perfectly.
All right, good. Let's go ahead and get a round of epi in or 2.
Perfect.
So they're also going to give this patient a round of epinephrine. Essentially, epinephrine is adrenaline. What epinephrine does in this context is it increases the ability of the heart to come back into a normal rhythm. It increases the tone or how tight your blood vessels are, meaning it may help the patient achieve a normal blood pressure again.
Ventilate.
She's trying to get with the husband.
You ready for epi?
Hey, epi's going in.
She said as far as she knows, no med history, no.
Epi's in.
Ventilate.
I'm gonna go for a pulse too. Yeah, you're in. I'm gonna jump that a little bit.
About 50 seconds till next pulse check.
Good for me nicely.
All right, good. Yeah.
Ventilate.
I can feel the pulse right there.
You got a good pulse.
Yeah, I'm not sure if it's from the compressions or if she actually has a heartbeat, but I couldn't feel it earlier. I think I bet she does. Yeah.
Yeah. All right.
Alright, we have backboard. We have stretcher ready outside.
You can see here how the primary paramedics partner is talking about how are we going to get this patient out? Are we going to put them on the backboard? Are we going to put them straight on the stretcher? She's developing a plan to get this patient out of the house. Something that a lot of people don't realize is if someone goes into cardiac arrest, like is in the situation, we don't transport them unless we're able to get them back. There's no sense in transporting a dead body because we are able to perform all of the same resuscitation that the hospital can right there in your living room. And all of that gets much more difficult if we're bouncing down the road.
All right, 30 seconds until next pulse check. All right, 15 seconds.
Ventilate.
Recharging, keep going.
Okay.
Ventilate.
5, 4, 3, 2, 1. Pulse check.
You got a pulse.
Yeah, pulse. Cool. All right.
So from here, everything changes. We're no longer working a cardiac arrest. We're now trying to keep this patient stable, get everything figured out so that they don't go back into cardiac arrest, which we just resuscitated them out of. It can be very tempting in those situations just to load the patient into the ambulance and haul over to the hospital. But as this crew does an incredible job of doing, that is not usually the best course for these patients. What we need to be doing is getting them completely stable so that they don't go back into cardiac arrest, essentially die again, before we start transporting. We get them as stable as we can, and then we can take them to the hospital.
Blood pressure sat. I think the blood pressure
Respiration's down. She has spontaneous respiration about 12 right now.
Spontaneous respiration still goes. Keep diving. We got Ross at 103.
And now we're putting blood pressure cuff on the patient. We're putting SpO2 on the patient. Hopefully we're going to get an EKG of this patient here shortly. We're still ventilating the patient through that eye gel that we have in place. But this patient's not quite out of the woods yet. We need to get her completely stable before we start moving and getting her out of this house.
What's your right leg?
That's it.
Hey, well, we have a PEEP valve for that thing.
Yeah, it's in the bag. Hey.
He has mentioned a PEEP valve. Essentially what that does is it helps keep the patient's lungs inflated even when we're not delivering a breath. Otherwise, if we don't have a PEEP, every time the patient exhales is kind of like getting the wind knocked out of you, where it's kind of hard to get a breath back into the patient without having that PEEP valve that helps keep the lungs inflated.
Let's just see what the blood pressure is, and I'm going to stabilize first.
Just in case. Okay. Yeah. Actually, you have a stronger one.
Hey, when you had the, y'all had a year SPO too? This was okay. I think you just, that's awesome. That's perfect, dude. 173 over 93.
The patient's initial blood pressure here is 173 over 93. That's pretty high, but that's also normal in this situation. The epinephrine we just gave, that's going to have a pretty significant increase on our blood pressure. We gave it right before we got ROSC, which means that all of that's still hanging around in circulation, and it's going to kind of crank up our blood pressure, crank up our heart rate. As well as soon as we come out of cardiac arrest, you have that compensatory increase of heart rate, vascular tone, all that stuff. All the stuff is going to increase your blood pressure. Because we were just dead, now we're alive, your body freaks out and goes, oh no, and tries to dump everything it's gotten into staying alive.
I'm gonna switch this out.
Hey, are you mixing up push dose epi, bro? Okay, perfect.
I'm gonna get it ready.
I think we're just stabilizing, man. We're gonna get a good pulse ox real quick and just make sure she's good to go before we move her. What we don't want to do is move her and she codes on us and we just start all over again. So. Seems like her radial got a little
bit weaker. It's been getting weaker.
She's got a good femoral.
Her heart rate's going up a little bit too.
Yeah, give me a.
Okay, her heart rate's going up.
You can see a firefighter in the background talking to the husband. That's very important in these situations, is keeping the family as informed as we can. Unfortunately, it can be difficult, as obviously our priority is to do everything we can to keep the patient alive, but that can be very alienating to family if they feel like we're not communicating. So they're doing an excellent job of managing the patient as well as managing the family.
Brooke, you might want to be on point with that. Yeah. Yeah, I would get ready to give it.
You got good AC.
Fine right now. She's got some great ACs. I'm still not getting any good perfusion with this here.
So as paramedics about to take the patient's blood pressure, they have several things that are indicating that the patient is losing their blood pressure very quickly here. Essentially, her heart rate is going up, meaning the heart is trying to work harder to maintain the same blood pressure, and her radial pulse, meaning the pulse in her wrist, is getting weaker, which indicates that her blood pressure is also dropping. So they're going to give what's called push dose epi, which is relatively a very small dose of epinephrine compared to what we gave earlier to help just give a little bump of support to that blood pressure.
I can't hear anything. Hey, recycle that.
You can see here we're struggling to hear the blood pressure, which probably means that it's pretty low.
So she has a radio.
You got a good radio over there?
She's great, but
I don't feel one. Yeah, I don't feel a radio anymore here.
it's big, that's big. Do you want to hit her with some epi and just see if that will help get...
I'm completely fine with that, but I want it to be a group decision.
Yeah, you got it ready?
Yep, it's right here.
Okay,
Our
yeah.
bag's right there.
So
Let's-
new folks should be on anything. She's going to watch her for it's on 184.
Yeah, the needle starts to jump around 80, but I don't hear anything.
Okay, that's fine. Yeah, let's hit her with some push dose.
It's okay. That's fast. Did he say he's leaving where?
Okay, one of epi push dose is in.
So they just gave her some push dose epinephrine to help her blood pressure. He just said he couldn't hear anything on the blood pressure. They are barely able to palpate a pulse, meaning the patient's probably about to go back into cardiac arrest. What they do is they give her that little bump of epinephrine that will increase her blood pressure and wards off this patient going back into cardiac arrest and likely dying.
You want to start her on a drip just in case? Just get the pump out. Hey, what up? Can you look that up to back?
So we're watching this paramedic go out of the ambulance. He's going to set up an epinephrine drip, meaning the same medication we're already giving, we're going to set it up so that it goes in over time and it's not just that big, huge hit all at once. This is a little bit better for the patient as it maintains a steady blood pressure versus just cranking up the blood pressure and letting it drop back off and cranking it up and letting it drop back off. So push dose is an excellent tool to get to a drip. Ultimately, it should be used just as that, as a bridge to get to a drip. And they're doing a fantastic job of that here.
Hey, Ross,
Yes. 1 milligram a minute. Yeah.
Can we grab your...
Yeah. Where's that epi at?
The patient was in shock for rhythm and Ross with 10, considering any other on 150 IVIO over 10 minutes.
As always happens on these scenes, there's a lot going on at once, but they are currently getting a 12-lead ECG, which will give them an idea electrically what's going on in the patient's heart. The patient's having a heart attack. The 12-lead is a tool that we use to diagnose that in the field. They're also talking about doing an amiodarone infusion, which is that one of the medications we gave earlier to keep the patient from going back into cardiac arrest. What that amiodarone does is it may help prevent her from going back into a dysrhythmia such as VFib or VTAC. So here we're setting up this drip. We already mixed the medication into the bag, I believe. So now we're going to put the tubing through the IV pump, which just gives us very precise control of how quickly the medication runs in through that IV.
Can you let go?
Yep.
Isn't this?
All right.
And there we saw him drawing up some medication. It looks like amiodarone. It's kind of hard to tell in the video, but I'm pretty sure he's preparing that amiodarone drip for the patient.
Priority 3, sick person, 3184, East State Highway 199, lot 138, Redwood Harvey Park.
As you can see here, these are hugely complex patients to move because we have many IV lines going. We're still ventilating. The patient may be intubated. They have an IGL in this case, as well as getting our cardiac monitor out and all of our equipment out without leaving a lot of trash behind for the family.
Boston Street, Netherline, Elena, Garnet Road, Mark 5105.
1, 2, 3. Coming up.
As you can see there, the patient was just loaded onto the kind of like horns that stick out of the back of the ambulance called an auto load. It lifts the cot for us, and that we're able to glide the cot into the ambulance without having to do any lifting on our own. They're amazing. They're huge savers at the back. They reduce workplace injury, and they're safer for our patients. They can lift like 600 or 700 pounds, so they're awesome. They're becoming a standard. Hugely helpful tool for those of us that have them.
Hey, this is Amy. I'm about to get it going. Hey, we need some freaking tubing right here.
I've got amnio hooked in this AC when you're ready.
Alright, we got 100 and 100 bag of amnio. It's 1-to-1. Are you serious? There we go. 1, yes.
As soon as he does that amnio,
So there we just watched the paramedic program the pump. We're telling it how much medication we want to give the patient and how quickly. These pumps are incredible tools for us. When I started my career, I didn't have pumps on my ambulance, and we had to manually figure out all of our drips. It was not particularly safe, but due to funding, that's just kind of what we had. Anymore, a lot of our agencies are now moving to having IV pumps in the ambulance, which is awesome.
how are we doing on pressure?
It was faint a second ago. I haven't taken it over.
Amnio's going if you want to timestamp that.
She's taking breaths on her own. We're just assisting her right now, okay?
I'm gonna try to get a pressure on her.
How old is she? She is,
Your other chair.
We see the, I believe, husband enter from the side of the ambulance. The crew is awesome, and they allow him to come see his wife, and the husband is behaving very calmly and making himself a great visitor.
It's ready your amnio.
Okay, thank you.
She awake?
No, but she's starting to open her eyes a little bit more.
Yeah. Let's just figure out what her blood pressure is.
100 over, literally 100 over 80.
100 over 80?
I just took a manual.
Okay.
Yes. And it was clear as day.
Yeah. I would go low dose ketamine.
So here they have made the decision that they're going to intubate this patient. They already have that rescue airway in place, but they're having trouble with her oxygen saturations and perhaps her capnography, so they're choosing to do a more definitive airway where we place a endotracheal tube into the trachea and use that to ventilate the patient directly. To facilitate this, we do what's called the rapid sequence intubation or delayed sequence intubation. Essentially, we use a sedative to make sure the patient is relaxed and they're not going to remember the event, and then we push a paralytic, which temporarily keeps the patient from moving so that it optimizes our ability to intubate. From there, we take what's called a laryngoscope and we open the patient's mouth and look at their vocal cords. We then place the tube between their vocal cords into their trachea and inflate a balloon that keeps it in place, and then we can ventilate their lungs directly.
That is a terrible question. I'll make it up front.
so we've still only given the 2 push-ups.
Taylor, I'm going to set you up for intubation.
I got another IV.
She's what? Yeah, we'll sit down.
Yeah, we got vomit.
Pull it or what?
No.
Yeah, don't pull it yet.
Oh, we're moving our hands. We're fine.
Yeah, I know. Just hold her down.
We see them set up multiple airway adjuncts, we see them set up suction, we see them set up a stylet and a video laryngoscope. The video laryngoscope is a excellent tool that we use for most intubations as our first go-to. It uses a camera to look at the vocal cords versus looking at them directly, and it makes intubation much easier. RSIs and DSIs require a huge amount of preparation, and they're doing a fantastic job in this case. We see the supervisor get into the narc safe and retrieve medications that we're going to use to sedate this patient before we intubate them.
Where'd that section go? Maybe of the altar?
Yeah, I just set it down right there.
Okay, thank you. I'm working on it now. I know,
Hey, somebody toss me a flush over there real quick.
How much are you doing?
I got 100 in the flush right here.
What are we estimating for high fat?
I'd say she's like 5'2", 5'3".
So we see the supervisor draw up ketamine, which is an excellent sedative. They also use rocuronium as their paralytic. Ketamine is great for these patients because it doesn't have a hugely negative effect on blood pressure most of the time, and it usually allows them to keep breathing. Then we use our rocuronium, which does paralyze the patient's voluntary muscle, including their diaphragm. This will stop them from breathing, but we've already taken care of that for them. Again, optimizing our ability to view the vocal cords and pass that ET tube into the trachea.
Here you go.
No.
This is 10 per. Marked ketamine. I would keep that. What's her blood pressure? I'd go 30. I'd go 30, and if she's not enough, then just give her a little bit more. Okay, yeah. You could give her 50 then. Yeah, just like we got. Oh, yeah.
They're doing an excellent job of closed-loop communication. They're confirming their medication dosages before they push them. They're confirming the concentrations before they push them. Just an excellent crew doing a very, very good job with this patient.
Like blood pressure is good and all that good stuff. Can you reassess that?
70 was just the last one.
Okay. Hey bro, do you mind sitting over there for me? And just use one hand, if possible. No, just give it to me, man. We're about to RSI. I want to rush right now. And honestly, it's
Going in now.
okay. Push that blood pressure again, please.
No,
Is she vomiting again?
Yep.
All right, you hanging on to that?
That section's right there behind us.
We see the supervisor place a blanket behind the patient's head to ramp the patient forward. This optimizes the position of the airway for intubation. At this point, we're pushing our sedative to help the patient relax and go back to sleep. She was resuscitated so effectively from cardiac arrest that she is starting to wake up. We're giving that sedative to put her back to sleep. That way she doesn't remember any of this. She did later say that she didn't remember any of these events. Unfortunately, the realities of intensive care are usually pretty ugly. But in this case, the patient did not remember any of this, and they're doing an excellent job of staying ahead of her pain and keeping her sedated.
Did we ever secure this or no?
Yeah, we just want to secure it.
Okay.
They popped it off when they thought we were going to take it out.
All right. Yeah. Hey, that 14 French catheter, we're gonna need that. Okay, that's good, that's good. You got suction. Where do you have the BBM out? Where do you have end tidal? You still sat 99%.
131 on 84.
Do we still have a downstream solution?
Okay. So when we get RSI, we're getting 50 more ketamine plus how much we're on?
Probably 30. 30 more. Depends on when she's ready to go.
Okay.
There's rock running. You get your ketamine. Both drugs are laying right here. I'll push them, or Brooke can push them. But I believe your ear external notch. You got suction, you got this out. Only thing we don't have out is C-color, but all this stuff is ready. Okay, so we'll do that. Checking one more pressure. First stats were 100%. We just lost it again. It's probably on that same hand. Is that what that is? Okay. There we go. We're back.
Chamber and that already.
Chamber.
One time side knee.
We got 50 ketamine.
100 of rock.
100 of rock. 50 ketamine. We got suction. We're trying to I'll try this one again.
Everybody ready? Anybody disagree with this? Okay. Somebody's watching SpO2. I'm going to push drug. You'll be cycling BP cuff. So we see a drop in the end tidal or the heart rate or SpO2, right? Obviously, you want to know about all three of those things. Yeah, just not DC it, but shut that saline down. All right, you ready?
Yeah.
Timestamp that ketamine for me. Rock's going in now. You got your timer out?
Yeah.
Everything's flushed through. Hey, so hang on to that gel just in case we can't get it, and we'll just throw it back in. Here's the lock in the unit.
To reiterate something that they said in their podcast, the patient is completely sedated at this point. She does not remember any of this.
Where are we at?
60 seconds.
Yeah, we're good.
Yeah. Bring it out. Bring that down.
What pressure pressure again?
That's clean it. Get out of her. But
Give it a timestamp this innovation. I got you. You got the two?
yep.
Alright. Innovation timestamp.
Co-pilot is on. Or sorry, the pilot room is at. Here we go.
Yep.
Alright, let me connect this.
I got a, where's the stethoscope at? I'm gonna listen real quick while you hang on to that. Going over?
Here we watch the paramedics remove the eye gel that was currently in place, place the video laryngoscope into her mouth, visualize the vocal cords, pass the ET tube into her vocal cords, remove the stylet, inflate the pilot balloon, place the capnography and the BVM onto the end of the ET tube, ventilate, they auscultate, make sure the ET tube is in the right place. They additionally confirm it with capnography. They then add some follow-on sedation to make sure the patient stays unaware of everything that's going on. They then set up the ventilator. The ventilator settings that they use are based off of her height, which give an idea of the size of her lungs. They then hook her up to the ventilator, make sure that all of their settings are working adequately for the patient, make sure that her vitals remain stable, and they take her to the hospital for continued care. This patient survived this entire ordeal and was discharged neurologically intact and returned to normal life. These paramedics did a fantastic job managing this patient. They provided early, high-quality CPR, they resuscitated her out of cardiac arrest, and when the airway they had wasn't working, they performed a rapid sequence intubation, swapping the eye gel for an ET tube. All of this was accomplished without her SpO2 or blood pressure dropping to dangerous levels. Incredible work by both the EMS crew and the firefighters that assisted them. I will link the original video in the description, as well as the YouTube channel for the EMS agency that provided this to us. If you have any questions, please post in the comments below. I hope you learned something today. Huge thank you to everybody that watched. If you liked the video, please like it. If you're interested in more content like this, please subscribe, and we will see you in the next video.